Thank you so much, everyone, for joining us. Welcome to the Hemophilia webinar series. My name is Dr. Victoria Kikinji. I work in KNH at the Hemophilia clinic, where we manage hemophilia patients as well as other bleeding disorders. Thank you so much for joining us from all over the country. You're welcome to listen in and learn. You're welcome to ask questions on the comment section. I hope you will enjoy the presentation from our presenters today. So, as we introduce management of hemophilia and the physiology behind it, I would like to introduce our presenters. We have Dr. Betty Kinywa, who is an ICHTC fellow. That means she has trained in hemophilia, and she works at a hemophilia center also in Meru. And we also have Dr. Kiogora Bolyongi, who is our clinical pharmacist here in KNH. He's also very key in helping us manage our patients, in helping us know how to dose our patients, giving them the correct dosage. He is also key in how we receive the factor concentrates for our patients, how they're stored, and how we dispatch them to other centers. So today you have a very rich panel, and I hope that you'll enjoy. So to start us off, we have Dr. Betty Kinywa coming in with the introduction to what hemophilia is as a bleeding disorder. Welcome, Dr. Betty.
Thank you so much, Dr. Kedenji. I hope I'm clear.
Yes, you are.
And I hope my presentation is clear as well. Everyone can see my screen?
Yes, we can.
Okay. Thank you. So today we'll be looking at hemophilia, and I'll add a bit about the surgical approach to the hemophilia patient. So this is the scope of what I'm going to cover today. And just to jump right into it, we're going to define hemophilia. And hemophilia is defined as an X-linked congenital bleeding disorder caused by deficiency in circulating coagulation or clotting factor. There are mostly two types of hemophilia. You have your hemophilia A, where it's factor 8 that's missing, and hemophilia B, where it's factor 9 that's missing. Can be congenital or acquired. We'll see how you can be born without hemophilia, then acquire it along the way. And it's basically a bleeding disorder, so it's characterized with bleeding. We'll look at this as well. This is just an overview of the coagulation cascade. So anytime there's injury in the body, what the body tries to do is come down here and form a stable fibrin clot. So in hemophilia, the intrinsic pathway is affected because this is where your factor 8 is and your factor 9 is. Someone might say, why not use the extrinsic pathway? Because you can see here, when you have damage to your any tissues, you activate your factor 2, which activates your factor 7. And then you come here 10, 2, 1 to form a fibrin clot. But actually, the extrinsic pathway forms a very friable and just a small clot that doesn't achieve hemostasis. So the extrinsic pathway is sort of like the spark, and then this thrombin that is formed here comes here to activate factor 8. So now the intrinsic pathway is the engine for you to form a robust clot that helps you achieve hemostasis. So for hemophilia, the intrinsic pathway is affected, and so for patients, there's arrest of the coagulation cascade depending on the factor that you're missing. So we can just look at the epidemiology of hemophilia. Hemophilia is actually quite common, especially with increased diagnosis and increased awareness of the condition. So over 1 million males have hemophilia worldwide, but majority are undiagnosed. But hemophilia A is much more common, with 80 to 85% of hemophilia being hemophilia A and 50 to 20% being hemophilia B. In Kenya, there are over 1,000 people who have hemophilia, and new are being diagnosed every day. So like we said, three common types of hemophilia. You have your hemophilia A, which is also called as classic hemophilia, and it's factor 8 that's missing. Hemophilia B, also known as the Christmas or rare disease. Rare disease because it was common in the royal family. And then there's hemophilia C that is very rare, and it's mostly common in the Ashkenazi Jews. And it's factor 11 that's missing. And now your acquired hemophilia. So acquired hemophilia is a rare autoimmune disorder, of course, characterized by bleeding in people with no personal or family history of hemorrhages. It develops later in life, and it's normally autoimmune disorder where maybe you had a malignancy or HIV or an infection, and so the infection mimics the antigen, which is your factor 8 and factor 9, and now you have antibodies that are clearing your coagulation factors even long after your illness has, whatever infection you had is gone. So levels of severity of hemophilia. So the clinical manifestation of hemophilia depends on the severity of the disease, and the severity is influenced by the plasma levels of clotting factor. To note is that severity of condition in any particular family is usually the same throughout the different affected members. For example, if you meet three brothers and one is a severe hemophiliac, chances are his brothers are like that as well. So in severe or moderate hemophilia, the bleeding tendencies appear early in childhood. These are the children who will be crawling when they're young and they bump on their gums, present with bleeding, or even during birth, during cord cutting. They present earlier in life, as opposed to the mild bleeders who are able to navigate through life undetected until they have like a major surgery or a major injury. And in our setting, it's circumcision. We'll be able to look at that as well. So there's something called antibodies, and we're saying that severe hemophilia patients, 15 to 20% will develop antibodies to therapeutic and prophylactic factor replacement. We'll look into that that statement will explain it in a few. Of note is that the average human being has a factor level about 60%, and that's enough. No one has 100% factor, meaning you have 60% of factor 8, factor 9, and that's enough to make you achieve hemostasis. But in severe bleeders, they have less than 1% factor, and they bleed spontaneously without injury. Your moderate bleeders will have 1 to 5%, and they'll bleed. They'll have minor hemorrhage, a hemostatic challenge or injury, and your mild bleeders are somewhere between 6 and 40. So they'll only bleed when there's a major hemostatic challenge or injury. So genetics, hemophilia is usually inherited through an X chromosome with a factor 8 or 9 gene mutation. So hemophilia usually affects only males who inherit an affected maternal X chromosome. So the mutation that leads you to have hemophilia is normally in the X chromosome. And since men have one X and one Y, if you have that mutation, you automatically present with the illness, because as opposed to females who have two X chromosomes, if the females have one mutation in one X chromosome, the other one is able to take over and you're able to produce factor. The good thing with this is that male hemophiliacs, sort of, we say quote unquote, the disease ends with them, because if they are to get a boy, they'll have to donate their Y chromosome, which is okay. And then the mom will have to donate the X chromosome for them to give birth to a boy. So unless it's unfortunate and an hemophiliac man marries the carrier female who donates the X chromosome, it's unlikely that a hemophiliac man can have a hemophiliac son, but he can have carrier daughters by donating this X chromosome. that has the mutation. So can females get hemophilia? Yes, they can, but it's rare. In cases where you get a female hemophiliac, both X chromosomes are affected, or one is affected and the other one is inactive. So I think the lionization is what is common, meaning that the female has two X chromosome, one is affected, but the other one is inactive. But females who have the X chromosome with hemophilia are called carrier females. The carrier is normally asymptomatic, um, but some present with mild form of bleeding. I think I saw it during my fellowship. There was a lady who had epistaxis. She would have menorrhagia, some bruising here and there, but not as severe as the male have it. And treatment is like the rest. I think Dr. Kyogora will tackle the treatment. So clinical manifestation, think anything. They can bleed from head to toe. So they have this low persistent bleeding from minor trauma or small cuts, uncontrollable hemorrhage after dental extraction. These are the guys who will come and say, had a dental extraction a month ago and they're still bleeding. That's not normal. So the other thing is that hemophilia needs a high index of suspicion. So if you see someone who is a man, had a dental extraction days or weeks ago, and now they'll even present with anemia, like a HB of 3, because it's been a slow, persistent ooze over time. Just quickly take the family history and their tests that you'll run. We'll tackle that as well. So they also tend to have epistaxis or bleeding of gums, bleeding after surgery, like circumcision, get upper GI bleeding from ulcers or gastritis, hematuria, they bleed into joints with no preceding trauma. There's something called a psoas bleed. You bleed into a psoas muscle, retinal hemorrhages, brain bleeds, all manner of things. So in severe hemophiliacs, like we said, they present early with bleeding from the cord. They'll have large cephalohematomas, gum bleeds when the child is crawling, or just unexplained anemia. So this is the typical hemophilic boy or man. They get bleeding into the joints, which we are calling hematorosis. So this bleeding doesn't have to precede trauma. So they'll go to bed, wake up with a knee that looks like that. The hinge joints are more common, your ankle, your knee, and your elbow. And then there's something called a target joint, meaning this child or this man will bleed consistently into the right knee. Another person will be consistently into the left knee. Another one will be to the right elbow. And they'll describe something like an aura. They'll know a bleed is coming. They'll have all these symptoms like tingling, just tingling, feeling of tightness long before you can clearly see. That joint will be very, very tender, warm to touch, and yes, and warm to touch. And um, previously, hematorosis has been mistaken for septic arthritis, and people have put needles there or taken someone to theater for a washout, only to have now to make matters worse because at least with the bleeding into the joint, there's a tamponade. So again, high index of suspicion. Um, The other thing is that we are really keen not to encourage joint bleeds because they lead to deformity and you find people who basically cannot walk without crutches or even they use wheelchairs. So we'll see how to treat this joint bleed. Um, Diagnosis. This is crucial and essential. So when you have a patient who you suspect has hemophilia, of course, take your history and then see whether there are previous history of bleeds in this patient. Ask them when you are circumcised, how was that? Many will tell them, I couldn't stop bleeding for 3 months. I got 6 pints of blood. Ask them, when you lost your teeth, do you bleed into the joints? When you're cut, do you bleed excessively? Ask about the brothers. How are your brothers? How are your cousins? Just the history is very essential in hemophilia and it's able to paint a picture. So now when it comes to lab, you do one test that is very important and it's your coagulation profile. and you're looking at the APTT. APTT is prolonged in hemophilia. The PT will be normal. So coagulation profile, APTT, it's prolonged. Once it's prolonged, now you know you're narrowing into your diagnosis. So the second question is to ask yourself, is this a hemophilia A or a hemophilia B patient? Because we look at treatment, treatment is with factor. You replace the clotting factor that is missing. So if you have a hemophilia B patient and you give them a factor 8, you won't be helping them. So the next question is, am I dealing with a hemophilia A or B patient? And now that's where you do your factor assay. So factor assay looks at how much factor 8 do they have, how much factor 9 do they have. So any factor level less than 25% is diagnostic. So the lab is able to tell you this person only has 1% of factor 8, so that's a severe hemophilia, or only has 5% of factor B, or of factor 9, sorry. So now you know you're dealing with a hemophilia B. Do not be deceived. Platelet count is always normal in hemophilia. The other thing we do is something called inhibitor testing, and I think we'll ask ourselves what inhibitors are. There's something we call presumptive treatment, not encouraged, but where I practiced, sometimes we had the coagulation profile, APTT is elevated, but we didn't have the factor assay test readily available because we had to send samples to Kenyatta. But remember, we said that 80 to 85% of hemophiliacs are hemophilia A. So sometimes you give them factor 8 and watch them. If they stop bleeding, you have your answer. If they continue bleeding, you give them factor 9 and you watch them. If they stop bleeding, you have your answer. This is just something we did in the rural setting. Maybe Dr. Kithinji can tell us if we're on the right track. So what are inhibitors? Inhibitors are allo antibodies to exogenous clotting factor replacement products. What this means is that especially for severe bleeders, and remember we said that severe bleeders, this last statement, severe hemophilia patients, about 20% of them will develop antibodies. And you remember that we said severe bleeders have less than 1% coagulation factors. So now what you're saying is that this is somebody who was born with less than 1% of this thing we're calling coagulation factor. So when you come and give them exogenous coagulation factor, their body treats it like a foreign entity, so to speak. It treats it like an antigen. So they form antibodies against your treatment, against your factor. So they neutralize infused factor. For example, now they have antibodies against factor 8. So when they come with a bleed, you give them factor 8, it's quickly neutralized. The bleeding never stops. So it makes treatment of bleeds difficult, of course, common in severe hemophiliacs. And Dr. Kiogora will tell us how to go about it. There are fancy products in the market that are able to tackle this thing, but it's frustrating, so to speak, because now these patients normally need a huge amount of factor. You flood their system with it, so that if 50% is neutralized, there's still a bit in the system to give them hemostasis. So this is just a slide I put considerations for the surgical hemophilia patients, because this is a patient who is prone to bleeding. But then what if they can't and they need an elective case or an emergency case? Like they come with a strangulated hernia. You can't fold your arms and say you can't operate on this patient because they're hemophiliacs. So how you go about it is by doing a thorough pre and post-op assessment. You'll need to be in a facility where a hemophilia treatment center, where at least you have a hematologist, or at least you have a consult to a hematologist. You have a surgeon, you have an anesthetist, you have a blood bank. They need to sign a high-risk consent. You need to know their factor levels and test them for inhibitors. So intra-op, for major surgeries, you do 100% factor replacement. We'll calculate how you will be taught how you calculate this one. For minor surgeries, 50% is okay. You can do a factor infusion intra-op. So this one is better to do like a continuous infusion as opposed to a start dose, because you will prevent the peaks and the troughs. You can use your antifibrinolytics, this is your tranexamic acid, and then the surgeon needs to use a surgical technique that minimizes trauma, ensure meticulous hemostasis, use drains only if necessary. Local anesthesia with adrenaline can be used for vasoconstriction, and you can use fibrin sealants, especially in dental procedures. Post-op, the World Federation of Haemophilia recommends replacement therapy for a duration of at least 3 days for minor surgical procedures and at least 7 to 10 days for major surgical procedures. I need to be keen with such a patient to check vitals, check the HB, factor level, and daily wound assessment, just to make sure it's not oozing or it's healing well. This is worth noting that during the circumcision season, you get these men, circumcised males, who got circumcised but they're still bleeding, or they formed a large hematoma. These are the people you need to have a high index of suspicion for. And I can tell you, you've seen on all manner of things. And the thing with bleeding from hemophilia is that it's slow but persistent. You can put a stitch, you can dress your wound with Surgicel, you can put a tourniquet, you can dress it up with a bed sheet, but it's always going to continue bleeding. So if you find somebody who's been bleeding, it's been days since they were circumcised, weeks even, suspect hemophilia, take your history, take your quack profile, look at the APTT, and do as we said. There's gene therapy for hemophilia A and B being offered, unfortunately not in our country as yet. But in other countries in Africa, like South Africa, I know they're doing gene therapy and it's almost curative for hemophilia. And especially for severe hemophilia, it's life-changing. You can imagine hemophilia is a painful condition. So you can imagine somebody who is always in and out of hospital, getting factor, injecting themselves, getting bleeds. Then suddenly they can form a decent amount of coagulation factor and now they no longer get bleeds. It's life changing. You get an adeno-associated virus 5, AAV5, that is injected via IV, and then it homes to the liver and configures your DNA such that you start producing factor. The bad thing with it is that you form antibodies to this virus. And people who've undergone gene therapy, with time, if you follow them over 5, 10 years, the levels keep dropping. So some of them will end up to a point where their levels are so low, now they need factor again, but you cannot have a repeat gene therapy because you already have antibodies to the virus that is used. But with hemophilia B patients, there's like excellent prognosis and outcomes. Hemophilia in Kenya is under a member organization called the KHA, the Kenya Hemophilia Association, and there are multiple HTCs, which is hemophilia treatment centers in Kenya. There's one at KNH, Moi Eldoret, Coast, Kisumu, Kisii, Meru, Nanyuki, Garissa, Tana River, Narok, Bungoma, Kakamega, Hola, Kitui. And if I've left some, Dr. Kithenji can tell me. So if you're in Meru and you have a patient you suspect has hemophilia, just find a way of contacting the hospital. There's a clinic there, there's a doctor there, there's a nurse there, and there's factor there. And there are diagnostic tools. They are just waiting for the patient. If you're in Nanyuki, Kisii, everywhere, so don't be stuck with a hemophilia patient twiddling your arms. All these clinics are running well stocked with patients who are being followed up and whose life has been changed for the better. People with hemophilia are now recognized by the Kenyan Constitution as people living with a disability. So they're able to enjoy all the perks that comes with that and all the advocacy that comes with that. So the donor factor is free of charge in Kenya because it's the factor that you infuse patients with, it's free of charge because it's donation from your WFH, World Federation of Hemophilia, your Novo Nordisk, and your Roche. So hemophilia patients really shouldn't struggle when there's all this afforded to them. I put this point as the last one, meaning prophylaxis in the future. In developed states, like in South Africa, they have something called prophylaxis, meaning you and I have factor, so I can go and play football, play rugby, bump my head on the tree, and I won't quote unquote bleed to death, so to say. Like I'll be able, if it's a minor bleed or a moderate bleed, I'm able to achieve hemostasis because I have factor in my body. So in patients with hemophilia, what some nations are doing is that they're given prophylaxis, meaning depending on the half-life of a factor, if a half-life is 2 days, they infuse themselves with factor every 2 days. So they have this level of factor nice in their bloodstream almost perpetually. So it prevents them from bleeds. And there's also another drug that does the same. It's used in prophylaxis, given once a month subcutaneously, called Hemilibra. Doc will tell us more on that. But it also helps with prophylaxis. And this is where the world is moving. And I think it's a good thing to talk about that our hemophilia patients, they don't have to get injured because how it happens in Kenya is that una bleed, unakuja hosi, we give you factor, you go home. You bleed, come back, go home. So would love to be in a place where they are injecting themselves prophylaxis and they are able to do, because we even tell hemophilia children, don't play rough sports, don't, because we are afraid you might bleed. But with the prophylaxis, then a child or a man is able to lead a normal life. So this is something we can advocate for in the future. With that, I come to the end of my presentation. Thank you. Um, any questions are welcome.
Thank you
Any
so
questions?
much,
Yeah.
Betty.
Yeah.
Thank you so much. That was a wonderful presentation. You are very eloquent and we could hear you clearly. And I'm sure our listeners have learned something about hemophilia, the genetics, the types, the severity. We know that there are different severities from mild to moderate to severe. And we've also learned that diagnosis is possible by a simple coagulation. And if the APTT is raised, then we should be able to request for a factor assay, which will definitely give us a diagnosis. And we've already been told that the symptoms are very clear. It's a slow, prolonged oozing that does not really respond even to, like mild pressure. And with that, I think we could go to the next part of our presentation, where Dr. Kiogora is going to take us through the management of hemophilia. Please, I encourage all participants to put your questions in the chat section, and towards the tail end of the presentations, we will be able to go through them and answer them one by one. Thank you so much. Welcome, Dr. Kiogora.
Okay, good afternoon, everyone. Okay, good afternoon. Hello, good afternoon, everyone. My name is Dr. Joshua Kiogora, a pharmacist at Kenyatta National Hospital. I'll be taking us through the next series of the presentations on the management of hemophilia. So management of hemophilia involves a replacement of the missing factor pain management, adjunct therapies and physiotherapy, but physiotherapy will not be covered in this session, to be covered some other time. So when it comes to management of hemophilia, pharmacist perspective, we have to go back to the clotting cascade because it's the one that will guide us on how to manage hemophilia patients. So under clotting cascade, usually the extrinsic pathway which is the first one to respond in case of an injury. Then we have the intrinsic pathway. So extrinsic pathway response within a few minutes. We have a tissue factor, which is usually circulating in plasma, and factor 7 together, acting together, forming, activating factor 10 to factor 10A, and then generating a fibrin clot. And then the intrinsic pathway, which is the one that has a loop and it is continuous and will be able to form a stable fibrin clots, is activated by exposure to collagen, which exists in tissues. We have a factor 12 being converted to factor 12A, 11 to factor 11A, and then 9 to 9A, then factor 8 working together with factor 9 to form factor 10A, which is in the common pathway. So now in hemophilia patients, as we've heard before from Dr. Betty, hemophilia A, there's an issue with factor 8. Then in hemophilia B, there's an issue with factor 9. And then in hemophilia C, there's an issue with factor 11. In hemophilia A, what we need to use to manage these patients if there are no inhibitors is factor 8. In hemophilia B, what you need is factor 9. And in hemophilia C, what you need is factor 11. But hemophilia C is quite rare. It's about 1%. Hemophilia A, 80 to 85% of what the patient you have, the incidence of imbalance, it will be 80 to 85%. Hemophilia B will be 10 to 15%. Hemophilia C will be 1%. So in order to be able to manage these patients, we have to know whether these patients have, in terms of severity, whether it's mild, moderate, or severe. So if you have a factor level in your blood, in your body that is between 35 to 40%, that's mild hemophilia. If it's between 1 to 5%, that's moderate, and if it's less than 1, that is severe hemophilia. So also, we have types of bleeds in hemophilia, where we have major bleeds or minor bleeds, and the dose calculation for the factor to give will be dependent upon whether it's major or minor. Major surgeries also characterized as major bleeds, so you correct the factor at 100%. Minor, you can correct between 40 and 60%. So when it comes to management, I will go into where we have come from, where we are now, and where we're going in the management of hemophilia. Before the advent of recombinant factor concentrates, what we was used to the management of hemophilia was whole blood or blood products, whereby you had whole blood, fresh frozen plasma for both factor 8 and factor 9 deficient patients, and cryoprecipitate for factor 8 deficiency. So, a fresh frozen plasma is as about 200 international units of either factor 8 or factor 9, and cryoprecipitate has 100 international units of factor 8. So where you don't have actual factors, you can also use the blood products for the management of hemophilia patients. But because of some challenges that were faced then, if you use these blood or blood products for the management of hemophilia, there's a risk for getting some infections. So some people decided we need to manufacture our own factors. So that's where now we went to actual factors, recombinant factors of factor 8, factor 9, and factor 7 for the management of hemophilia patients. Now, the replacement of factor is calculated this way. So first thing you need to know is that 1 international unit of factor 8, if you prepare 1 international unit of factor 8, it will raise the plasma level of factor 8 by 2%, and 1 international unit of factor 9 will increase the plasma factor 9 level by 1%. So when you are calculating from this slide, what it says is, if you have a patient and you want to correct the factor level by 100% for hemophilia A, then what you need to do is to give 50 international unit times weight. If you give 50 times the weight of the patient, then you will have corrected by 100%. For factor 9, what you do, if you want to correct at 100%, you say 100 times the weight of the patient. So this is the calculation. So factor 8 dose is the target percent. So in this case, you can target a 50 if it's a minor bleed, or you can target 100% if it's a major bleed. So the dose calculation is given as now for factor 8. It will be, you want maybe to target 100%. And let's assume we have a patient who is 50 kg. So the target for maybe a major bleed will be 100 multiplied by the weight of 50, then you multiply by 50. Or simply you can say, because factor 8, one unit raises the factor level by 2%, you know, if you give 50, it will raise, and so you say 50 multiplied by weight, which is 50 times 50, will raise the factor level by 100%. So that means you require a bottle of 2,500 international units of the factor concentrate that you'll administer as the first dose of the patient. So to repeat again, we are saying if you have a patient who is 50 kilogram and you want to give a factor at 100% for hemophilia A patient, you give, you say it's 100, that is the 100 you want to correct, 100 multiplied by the weight of the patient, which is 50, times 0.5, which gets to 2,500 international units. So, or you can also say, because for factor 8, it raises the factor level by 2%, you can say, I want to achieve 100, so I'll say 50 multiplied by the weight, which is 50 times 50, which is 2,500 international units. So something else to know, the factor 8 comes in international units. You can have a bottle of 250 international units, our bottle. We have another one of 500 international units, can have 750 international units, 1,000, 1,500, 2,000, 2,500, and 3,000 international units. So if you have a bottle of the factor that has 2,500, then you can administer intravenously to the patient that bottle. So the subsequent doses, you look at the half-life of the product. So we get different donations of this factor. Some with the half-life maybe for factor 8 of maybe 8 to 12 hours. Others have extended half-life of maybe 10 to 20 hours. So you can give one dose today, and then you give the next dose the next day. Now, depending on whether it's a major bleed or minor bleed, or where you have a surgical procedure or not. So the next dose is usually half the dose you give. So for a patient that we had calculated for factor 8, we give 2,500. So you're supposed to give half of that. So, and then you have to look at the desired peak level and maybe trough levels. So option number 2, instead of giving that what we've given the second day, half of what you gave, you can give for factor 8 for international units per kg per hour, and this will maintain what you want to achieve. So for hemophilia B, remember we have said that factor 9 raises the factor level in the body by 1%. So the actual dose, if we have a patient who is 50 kg, the dose will be, maybe they have a major bleed and you want to correct at 100%, it will be 100 multiplied by the weight. So that would be 100 times 50, so that's 5,000. So from this, you can see that you use a higher dose of factor 9. You're using a higher dose of factor 9 for the same weight. So you're saying 100 times 50, getting to 5,000. So if you have a bottle available from donation, or what you have of factor 9 of 2,000 and 1,000, and maybe 2,000 and maybe 1,000, you can use 2 bottles of 2,000 plus 1 of 1,000 to achieve the 5,000 international unit for the first dose, and the second dose will be calculated as that for factor 8, whereby you have to look for the half-life of the product. If it's 24 hours, then you give the next dose after 24 hours. If it's extended, then you can give after maybe 3 days or 3 or 4 days. And the dose is usually half of what you had calculated for the first dose. So you can also give at a continuous infusion of 6 internal units per kg per hour of the standard half-life factor for the second or subsequent doses after giving the first dose. So other therapies that are used in the management of hemophilia, we have one, amino B, arginine vasopressin, antifibrinolytics, that's epsilon aminocaproic acid and tranexamic acid, used in the management of hemophilia, but we avoid tranexamic acid in hematuria because of the risk of formation of an occlusive clot in the lumen of genitourinary tract structures. So we have overview of a patient with an inhibitor, as has been covered on inhibitors. So what happens with a patient with an inhibitor is that there is the slide we covered on factor 8. Now, somebody has something that is inhibiting the activity of that factor 8 now. So if you are managing an hemophilia patient with the inhibitors, then it means you'll be giving factor, and then the factor is being neutralized. So these patients, if you approach the management using the intrinsic pathway, then you are not likely to manage them where appropriately, and then the bleeding will continue. So in these patients, we focus more on the activated forms of the factor. Maybe you can go to the extrinsic pathway and give things like a drug called FABA. That is factor 8 inhibitor bypassing agent, or we can give Novo7, which is a factor 7 activated form. Yes. And that's a FABA. So, and then Novo7, or we can use activated thrombin complex concentrate. So now in hemophilia, especially those who have inhibitors, we do a form of prophylaxis because these patients are likely to bleed. Most of them have severe hemophilia or moderate hemophilia. So there's an agent that has been developed to try and help these patients. So in the developed world, we have 2 forms of prophylaxis. There are those patients with moderate and severe hemophilia who do not have inhibitors. So they're given low dose of the factor so that we can have a form of prophylaxis to prevent them from bleeding and to make their lives better. But in our setting, because we are relying on donor products, we don't do this form of prophylaxis. So what we have is a methicillin prophylaxis. So, and in a methicillin prophylaxis, this is how we calculate the dose. So we first of all have a loading phase whereby you give the patient 3 milligram per kg subcutaneously once every week for 4 weeks. So a patient will come, you give them subcutaneous. Remember, all the others we have covered have been given intravenously, but this one is subcutaneous. So the loading dose is 3 milligram per kg subcutaneously once weekly for 4 weeks. Now, assuming we have patient with 50 kg. So the loading dose we require is 3 times 50, which is 150 milligram of the dose. Now for maintenance, we have several options that are effective, but what we are using as KNH is 6 milligram per kg every 4 weeks, just because it's convenient. So, but effective. So every 4 weeks, a patient with 50 kg will get 6 times 5, which is 300 milligram of emicizumab. So now there's a catch on emicizumab. So we are relying on donations. Now for the last 3 or 4 years, what we have had donated to us was the first Milibra, which is 30 milligram per ml. 30 milligram per ml of emicizumab. So now let's do the calculation for the loading dose of a patient with 50 kg. So the loading will be 3 mg per kg per week for 4 weeks. So it will be 3 times 50, which is 150. So then, and what we had, or what we have, is the emicizumab at 30 milligram per ml. Then that means we'll need 5 injection sites, and it's sorry, well, that means we require 5 bottles of these, and then this one is 5 times is 30 mg per ml, sorry. So, and what we are supposed to give is subcutaneous. We can give a maximum of about 2 ml. So then it means we require 3 injection sites. So there's 3 injection sites subcutaneously, especially for those with higher weight, they are not likely to comply. So, but last year, but when we got something with 60 mg per 0.4 ml, which improved on compliance, because most of the patients got required just 1 injection subcutaneously for the continuation dose every month. So if we got a range from the first two are what we have gotten donations from, that is 30 mg per ml and 60 mg per ml. But currently we have this Emilibra or emicizumab being registered. I think Roche it's registered in the country, and with retention. So if we ever got maybe all this range from 30 mg to 60 mg, 105 and 150 mg per ml, it would improve on compliance for the patients, especially the adult population, those who have a inhibitor. Okay. So complications of hemophilia, we can have inhibitor formation, we can have hemophilic arthropathy, and infection from plasma-derived products, which we are not using a lot these days, and patient can have cardiovascular diseases. So new approaches in the management of hemophilia. So far I've covered where we've come from, where we are now, and this is where we are going. So we have gene therapy. Gene therapy has come up as something new in the management of hemophilia. So, so this is where you use viral vectors, maybe something like adeno-associated virus. So you deliver a functional gene copy to the patient liver cells, which will then produce the clotting factor continuously. And it's a single IV infusion containing the functional gene. So the hepatocytes will take up the gene, and then they continuously produce the factor 8 or factor 9. Okay. So we have for hemophilia B, so we have an FDA-approved drug called tridmimgenics, or extracogen diastereotyric drib. For hemophilia A, there's a drug in advanced clinical trials with promising results of annual bleeds reduction by about 80% in some patients. So the only challenge with this for the drug Hemgenics that has been FDA approved is that it's quite expensive. It can cost about 3.5 billion Kenyan shillings for just one single injection. Okay. So, and other thing that I can add on hemophilia. So for pain management of hemophilia, we try to avoid non-steroidal anti-inflammatory drugs. That is things like aspirin, anything, NSAIDs, we avoid them. So in hemophilia management of pain, we use either paracetamol or opioids. Okay. And I think that's the end of my presentation on hemophilia management. Thank you.
Thank you so much, Dr. Kyogora. That was a wonderful presentation. I've also learned quite a bit about dosing and how to, just pace the follow-up doses for our patients. This was a very timely discussion because we continue to manage our patients across the country. Thank you for all those who joined, and also for those who are in other HTC centers across the country. I hope you're learning something. Kindly put your questions or comments in the comment section so that we can go through them. That was very, very insightful. And we hope that you've appreciated the scope of hemophilia. Today, we are just basically doing an introduction to what we do, or what entails the management and the care of hemophilia patients. And I hope that a majority of you have learned something. Thank you, Rukia, for your comment. So we will now start going through the comment section just to see what questions are available there. And then I will request our presenters to also join in and answer, and then we can continue learning. So let me just a minute. So I've also seen questions about fever. I've seen questions about the dosing of fever. So usually, like Dr. Kyogora has mentioned, FIBA, which is an acronym of factor VIII inhibitor bypassing agent. This is mostly the treatment for patients with inhibitors. And it works for both hemophilia A and B, simply because it is a concentrate of different factors. It has both 2, 5, 9, 8, 10. Yeah, it has a number of clotting factors within it. And so, including 7, which is very key. And so with that, it's able to bypass the antibodies and activate the coagulation cascade. And so these patients are able to clot. And we do calculate the dosage through the, we still use their weight. Their weight is key. And usually we do 25 IU multiplied by the kgs. So sometimes in children, we may go slightly lower simply because this is a very potent drug, and it has the risk of causing clotting or hypercoagulation. And so we don't even give it as a push in our setup. What we usually do is we put it in some normal saline in a solus-set, and then we give it a slow infusion as we monitor the patients, so that in case the patient has any reactions like headache, vomiting, or nausea, we're able to manage that and then proceed with the infusion of FIBA. So FIBA is ideally, or Novo 7, which is the other product. These ones are used majorly for the treatment and management of inhibitor patients. So let me start with the first questions up there. In a minute. So I think about the CPD points, there's some people asking about CPD points. Nelson will be able to answer that. I'll just go to the clinical questions. Okay. So Gabriel is asking, is it possible to incorporate screening during blood donation drives? Is it possible to incorporate screening during blood donation drives? I believe here, Gabriel, you mean screening for hemophilia. I think, let me check that over to Dr. Betty. Dr. Betty, are you able to answer that?
Yes, I can try to the best of my ability. No, I don't think it would be feasible to incorporate screening for hemophilia during blood donation, simply because it's a bleeding disorder. It's possible that our patients need blood. They're not the patients donating blood, they're the patients being donated for blood. Then the second thing is that it is like we said, it's relatively rare. You can imagine in Kenya, we are talking about 1,000, max 2,000 in 150, in 50 million. Then number three is that the illnesses that are screened in blood are targeted. The targeted illnesses that are screened are those that if you donate this blood to someone, will they acquire this disorder or illness? For example, your HIV, your hepatitis B, and whatnot. So hemophilia being congenital and non-transmissible and non-communicable, then really, I don't think it would be effective, is what I would say.
Okay,
Also,
thank
screening
you.
sorry, it's rather
Yes.
expensive, isn't it? If a quag profile is not a cheap test to have, and then after
Yes.
that you do your factor assay, and only KNH is able to do factor. Okay, in at least from Meru, Embu, Nanyuki, Muranga, only we send our samples to KNH unless things have changed. So not the most effective way to screen, I would say. The most effective way to screen is your family tree. If you capture one patient, you draw that family tree and get all the bleeders. And what you're doing right now, creating awareness so that we don't miss patients who come to casualty with bleeding in the community. People who have deformed legs who just nobody knows what's happening with their legs, they're ever swollen. So I think this is the best way to go about it, creating awareness.
Yes, I agree with you. Yes, thank you so much, Doc. I agree with you. The next question, Dr. Shem is asking, please comment on how you calculate factor 8 in patients with inhibitors. I'll give that to Dr. Kiogora.
Okay, I'll try to answer that question. So, please comment how you calculate factor 8 in patients with inhibitors. So, what you do, you double the dose. So, if it's a major bleed, you multiply the dose, so you give it at 200%. That's what we do.
Thank you, Dr. Yes, that's what we do in inhibitors. In a setup where you do not have bypassing agent, you double the dose of what you have. So instead of giving 100%, maybe it's a major bleed, the patient has intracranial bleeding, you give even at 200, and then you hope that whatever percentage will remain after inhibitors have, whatever percentage will remain in circulation, like what Dr. Betty said, will be able to kind of start suppressing the bleeding. Dr. Betty, do you have any comments for this question?
Been beautifully answered.
Okay, thank you. All right, let's move on to the next question. kindly comment on the use of FIBA and OVO7 and dosage calculation. And I think this has been covered fully, but maybe Dr. Kigoro can just give one more comment about it.
So I think I can comment on that. FIBA and OVO7. So FIBA, we mostly use it for those patients with inhibitors because it contains factor 7, factor 10, factor 2. So the dose calculation, we normally dose it at 50 to 100 units per kg, and the frequency is about between 8 to 12 hours, where depending on the bleeding severity. So for OVO7, the dose is calculated as 90 microgram per kg IV, and the frequency is 2 to 3 hours until the bleeding stops. So the challenge we have with this OVO7 is that we haven't received OVO7 donation in a long time as a country. So actually, sometimes the surgeons require it in liver disease or surgeries where the patient undergoing procedures like liver resection or transplantation, and we've had to borrow from other centers, donors around. So luckily enough, when we required it, we got it. But maybe in the future, if we are able to get this drug and access program, maybe SHA, then we can be able to stock them as a country for these patients. So if we get OVO7, it will not only help the hemophilia patients, it's likely to help those people with liver issues that requires transplant. It also used in Glanzmann thromboasthenia, where there is a absent response to platelet transfusions. So we are hoping that in future we get an opportunity and a SHA access program for these products to be stocked. So some countries have done that. We have South Africa, I think some West African country and Egypt are ahead of us. So we can try as a country to catch up and continue being the leader we usually have in other areas in East Africa and Africa as a whole.
Thank you so much, Dr. Kigoro. That was very, very good. Dr. Betty, this one is yours. What is the approach for a non-hemophilia patient who is supposed to undergo an obstructive surgery, considering the risk of bleeding?
The question is a non-hemophilia patient
Yes, known. This is a non-hemophilia patient.
who's supposed to go a surgery for an obstruction.
Yes, to undergo an obstructive surgery.
Okay. So number one is to know the factor levels in this patient and to know whether the patient has inhibitors or not, because that will influence a lot. If they have inhibitors, you lean towards you'll either give high dose factor or lean towards your bypassing agents. And if they don't have inhibitors, that's a good thing for you. Number three is to ask yourself, is the surgery major or minor? So not very clear, but minor versus major, there's a lot that you can use to know. So a major surgery is a patient under GA. A minor is like under local. Major, the time, more than an hour. Minor is shorter. A major, how much blood loss, how tissues, are you going through a lot of tissues, such things. And then number three is to ensure that that hospital has a lot of factor so that you're prepared for whatever may. And then, like we said, if it's a minor surgery, you can get away with 50% replacement. Major, you need to replace 100% of factor. Intra-op, you need to infuse factor. And then post-op, like we said, if it's a major surgery, you need to give factor every day for at least 10 days. If it's a minor, you can stop at your 5-day mark. So, yeah.
Yes, thank you for that answer. Very comprehensive. Yes, for any surgeries, we always encourage wherever the place, please make sure you do thorough screening for your patients. Even if you have been seeing them, always do your inhibitor screen, because conditions, even infections, can trigger inhibitor development. So that would be important. The other question is, how is lifelong factor replacement done? I don't know what Shadrach meant here, but how is lifelong factor replacement done? Dr. Kiogora?
So I hope I understand the question well. How is lifelong factor replacement done? So basically, in our setup, we actually manage patients more of if they bleed, they come and then we treat like just because we don't have enough factor. We are relying on donations. So only those patients who have maybe severe hemophilia, so we put them on a mesenchymal prophylaxis. Those who just bleed occasionally, we wait for them. When they bleed, they come, we give them factor for a few days, and then when they recover, we wait. Yes. But in an ideal setting, what's supposed to happen, if a patient has severe hemophilia, they are supposed to be put on a low dose factor prophylaxis. We are not doing that just because we don't have enough factor. If we get enough, we put all the patients who have severe hemophilia on low dose factor prophylaxis, which is ideal, and the developed world are doing that way. So I hope in future we get enough, and then we do what is supposed to be done. Thank you.
Thank you so much, Shadrach, for that question. I have Naomi asking, or whether this is a question. Factor 8 has been out of stock at pantry, specifically in Busia. Is it available now in KH?
So how come you don't have factor 8? We can give you some, but what is we don't have currently enough stock, but in case of emergencies, we have some, is factor 9 and emicizumab, which is coming anytime from now. But the catch is that the emicizumab, I think the hospitals that use it majorly is Kenyatta National Hospital and Moi Teaching and Referral Hospital. But in case you have a shortage of factor 8 in your facility, then reach out. We can be able to sort you out. Thank you.
Thank you, Naomi, for that. Please make a follow-up, and Dr. Kiogora can organize factor 8 for Busia County. We probably have, let me see. Okay, someone is asking, please comment on the relationship between cancer and hemophilia. Is there a relationship between cancer and hemophilia? That is Janet Hadisa. Dr. Betty?
Maybe some malignancies can predispose you to acquired hemophilia based on how your body perceives the cancer cells, and if there's mimicry with the malignant cells sort of looking like your factor 8 or your factor 9. So maybe that's the relation I can think about. But a hemophilic person is not exempted from getting malignancy. If they, let's say they're a smoker, they are predisposed to your lung CA. If all the risk factors and the genetic factors are in play, then they can also get a CA.
Thank you so much for that answer. Very well said. I agree, because I've also seen hemophilia patients having other comorbidities, so they're not really exempt from getting other issues, even hypertension, diabetes. So it just depends on how their physique is, or whatever the physiology is at play. So they're managed in according to what they have. So we could be managing hemophilia on our end, and they still have to follow up on their neurology clinic or their diabetic clinic or their oncology clinic. So they're really not exempt. There is no particular relationship, but I would say that immunosuppressive diseases do predispose our patients to developing things like inhibitors. So, or you can find even a patient who had an immunosuppressive state and they were not hemophilic and they develop acquired hemophilia. So it is true that in some sense that a cancer or a cancerous tumor can trigger acquired hemophilia. Okay, I think we are done with the questions. I do not see any more questions in the chat section. In case you're left out, you still have a few minutes to go. Any other questions from the listeners? Thank you so much for listening in. Thank you so much. I hope Nelson will share the presentation with you in due course of this week. We also welcome you for the rest of the presentation. This is the first of the webinar series as we gear up to World Hemophilia Day, which is happening on the 17th of April, and we'll be celebrating it at KNH. So we do welcome our listeners to celebrate with us wherever you are in the whichever part of the country you will be. If there's a hemophilia center near you, you could join them and help us celebrate or just support our hemophilia patients. So this year's theme is diagnosis as a first step to care. So next week we are going to be having the lab team presenting to us on diagnosis. They're going to break it down, and we will share more about how, as a clinician or even as a parent or a relative or a caregiver, you can go about diagnosis of someone who has bleeding tendencies. So I hope that you will block your time next week on Wednesday, same time 2 to 3:30 p.m. We will be having the webinar on lab diagnosis together with another topic. We will continue this series up until the 8th of April, and we hope that you'll be joining us and learning. Please come with your questions, and we hope that you will enjoy. Thank you so much.
Thank you, Doc. Thank you, everyone. Have a lovely rest of the day.
Okay, hello everyone. Have a nice day. See you next time.